you are all working at Columbia, and this is the status board. All three of these patients can be seen, and it's your choice who you can go see. 14-year-old female, ankle pain, x-rays back that are negative. You've got an 80-year-old female, worsening generalized weakness since 2004. And then you have a 38-year-old male with left arm shaking. Student Dr. Franklin, if you wanted to go see someone, who would you want to go see? Anybody?
The 38-year-old male.
I like it a lot. The problem is the third years have already seen all of them, because that's what we do. We move the rack and we see the most severe cases. So I'll give you a little bit of background. He was at the Shake Shack a couple days ago. Since that time, his left hand is just kind of uncontrollable, erratic. He can do a lot of his activities while the arm's moving. It's never happened to him before. Had a light diet there, and then had some nausea, vomiting afterwards, viral URI, but he doesn't know what's going on with his arm. That's the menu. He only had one frozen custard after the burger. So let's go. Mark, what would you like to know? First of all, let me go back to student Dr. Franklin. When you go into the room, when you go see the patient, what's the first thing you do when you walk into a room when you see a patient?
Check the ABC.
And? IV O2 monitor. Why not? That sounds great. Mark, we're going to start the process. Now you're imagining you're going to go to this guy. You've got a 38-year-old male, left arm shaking. That's the chief complaint. What do you want to know? What do you want to do? He's hypertensive. It's like 180 systolic, and he's tachy to the 120s. Satting 100% of room air, speaking in full sentences, and in no acute distress. The arm shaking started yesterday. He noticed it after a bowel movement, and his left arm only. After the bowel movement, he left it's out of the bathroom, and happened once, and about 4 hours later, it happened again. But now it's been happening constantly. It's like 20, 30 times. They saw it in triage, and he's doing it in front of you. I can show you a video. This is when you ask him of his systems, he's saying yes to all this stuff. He's talked about chest pain. He's had like a viral URI. He had some rhinorrhea. He's got this cough. He had some like chest pain, intermittent chest pain last couple of days. He had some vomiting after Shake Shack a couple days ago, but maybe 1 or 2 bouts, but that's kind of resolved. Because of the way he's felt, he's kind of had this general malaise. He hasn't really eaten very much. So he's saying yes to all this stuff. Dysuria, polyuria, he's got joint pain, and he's here really because he's worried about what's going on in his arm. Family history. So his father has prostate cancer and hypertension. Mother, non-contributory. Good question. The question was, does he have a history of Huntington's disease in the family? No, he does not. Drinks alcohol socially, smokes maybe a pack of cigarettes every 2 weeks. No illicit drugs. Yeah, it's smooth writhing forms, but now it's a little bit more aggressive. Sudden onset after the bowel movement yesterday, then 4 hours later happened again, then resolved. But now it's just, like maybe 20 minutes in between that episode. It's lasting for about 5 minutes and resolving. No other neurological complaints for him. He has no twitching. He has no numbness and tingling in the extremities. Strength is strong throughout, he says. Good question. He likes it medium well. I called just for collateral. I called Shake Shack because otherwise that's what we do. Before you present to an attending, you need this information. Guayac and call restaurants. Good question, Dana. Diabetes type 1.
How well does he control sugar?
He thinks it's well controlled. He's had it since birth. He's had it since birth, and he takes Lantus every night. He doesn't follow his finger sticks, though. At this point in his life, he's been going for 38 years. He's not regimental about checking finger sticks and allocating his insulin. He's basing it on his general perception of how much he's eaten, how he's feeling, and he's dosing himself that way.
What was his finger stick in the eating?
Good question.
Is that working for him? Is that successful?
The nurse just came up to you with the finger stick of critical value. It's about 500. You going to start him on insulin?
Sort of no foods.
Okay, brilliant. It was yesterday, anterior chest wall pain while he was walking. It lasted for about 10 to 15 minutes, resolved. That was done on the review systems. He didn't come in telling you about chest pain. The sub I asked about chest pain, and now we're stuck working that out.
Okay, so you're not worried about his chest pain?
No, he's comfortable. He's not diaphoretic. He has abnormal vital signs, right? Hypertensive, tachy, but his chief complaint was left arm shaking. So, you know what I mean? Now it's starting to drift that way, but when you walk up there, that's not where you're going. You know, you're not going in there with a chest pain, Romy kind of mentality. He's tachy, no acute distress. Heart rate's 123, blood pressure's 160s. He's statting fine, afebrile. He's completely comfortable. He's not in acute distress. He looks too well, actually, on your exam. No rashes. His oropharynx is clear. It's a really benign exam. Neuro exam is only notable for these random choreiform movements.
No changes.
John, what do you want to do next? Labs? What do you want to see specifically? pH 7.38. So PCO2 is 52. PO2 is 23. Bicarbs 30.6. We've got a sodium of 126, potassium of 4.9, and glucose above 700, lactate of 6.75. All right. Greg, what do you want to order? Or you want more labs? His sodium is 125, potassium is 5.1, and creatinine is up 158. He's got a critical high. Glucose. LFTs came back. Can you guys see those numbers? AST of 1200, ALT of 600, ALK phos 606. So significant transaminitis. Critical high sugar, normal pH, transaminitis, elevated lactate. Tanvir, what would you do with EKG? He was complaining of chest pain review symptoms, but chest pain free right now. No, we didn't have an old one.
When his chest pain started, just like...
He had it yesterday. It was like intermittent chest pain yesterday. Would you activate? I guess my question is, would you activate?
No, I know.
Would you do a consult, but you wouldn't activate STEMI and do a dissection protocol? So we activated STEMI. They came down. We gave him an aspirin. I did a bedside fast and echo on him. I saw septal wall hypokinesis on my bedside echo, and also looking at all four quadrants. This is serial slide. Did you guys see serial CPC, by the way? You could actually click on the different body areas, and it would open up to a live. And that is actually serial. This is the right upper quadrant. Gallbladder. Jake, what's that? That's a Shake Shack hamburger sitting in his gallbladder. There's no fluid around there's no fluid, and I didn't see thickened wall thickness. I didn't see an extra fluid around the bladder. Left upper quadrant. You okay with that? As you can see, there's absolutely no wall movement, no septal wall movement on this ultrasound. And that's why I was worried. See any lung rockets there?
No.
No. We did a chest x-ray. Dan, you want to just start a differential? Anissa, what do you we see transaminitis? Hepatitis. Is this acute, or would this be like a chronic hepatitis? Right. Chronic might be a little lower, low 100s for a chronic hepatitis, but like 12, in the thousands, it might be an acute hepatitis picture. Toxins, shock liver. More labs coming back. No weight count. Platelets okay. Now you get the urine back. Glucose is 500. No ketones. He's got hyperglycemia. No ketones, normal pH. So what do we call that? Not DKA, it's the other one. The artist previously known as HONK, HSS. Hyperosmolar, hyperglycemic. So we got a troponin. Troponin was negative. PT, PTT okay. No, serum ketones were negative, and his TH was normal. We followed up on the hepatitis panel. That was negative. And we got a head CT, which was read as normal. So how are we gonna treat this patient right now? We know his K, his sugar is critical high. Jake, what are you gonna start? He's way behind, so we got to dump fluids in him.
He's got lots of mold.
How about that? He had a sodium of 125. Is that a real sodium? His sugar level is 900, sodium's 125. Do you know how to calculate that? 1.6 per 100. So he's actually about 137, his sodium.
All right, so he's okay.
We called MICU. We did a STEMI activation. They were less concerned about the EKG and less concerned that this was actually an MI, so they didn't take him to the cath lab. MICU was puzzled. We started him on an insulin drip and fluids, gave him a bunch of fluids. So what we had was hyperglycemia with significant volume depletion, a non-ketotic hyperglycemic state. We had the elevated lactate, thinking mostly probably a metabolic pathway abnormality as opposed to hypoperfusion. He had the transaminitis. Wasn't really a perfect picture of shock liver. Shock liver transaminitis usually 10,000 plus. Could have been a viral illness. And again, I just wrote out like mildly elevated transaminitis. You're thinking chronic hepatitis or maybe acute alcohol overdose. Moderate elevated, where this patient was, maybe acute viral hepatitis. And then severely elevated, you've got shock liver, aspirin, Tylenol toxicity. And then we have this hypertension with borderline EKG changes and possible septal hypokinesis. And the differential there was maybe a focal myocarditis from poor glycemic control. Some notes about DKA versus HONC. So the most common precipitating events in DKA or HSS, HONC with a C, is pneumonia or UTI or some kind of infection. You can have inadequate insulin therapy, which is probably what was going on with this gentleman, and compromised water intake from some kind of subacute illness, elderlies not taking in good PO intake. And that can lead into their HONC HHS symptoms. Other causes, MI, CVA, sepsis, pancreatitis, and sympathomimetic agents and cocaine use. So we had this Korea hemibolismus event that was going on for 2 days. Tanvir was thinking Huntington's. You can get that from ischemia, an infection, some kind of neoplasm. Also Wilson's disease. And thyrotoxicosis and lupus can give you erratic choreo hemibolismus forms. So can we put these two together? So basically we had a hemibolismus, hemichorea stemming from his hyperglycemia, which is, there's case reports of it. Very often you will see neurological changes on MRI and CT scans. You'll see hyperattenuations on CT scan. You'll follow that up with an MRI and you'll see T1-weighted hyperdensities on MRI. Our gentleman did not have any CAT scan change or any CT changes, so he did not end up going to the MRI. He ended up staying in the ICU for 3 days, and with good sugar control, his chorea movements dissipated and went away. There's not a lot of information on this HB hyperglycemia. Case reports only. It's considered a potentially reversible disease, which is great for the patient. And you'll see changes in the brain imaging. And usually it's happening in the basal ganglia. There's many different theories, and there's lots of debates of what's going on at the cellular level. And sometimes it can be the first clinical sign of a non-ketotic hyperglycemic event. It can also disappear within hours, but can last for about 6 months. Again, there's changes in the MRI and CT scan. The controversy is about the etiology of it. And Madroni, 1992, and his team proposed it was from calcifications going on in the basal ganglia. 1997, Chang followed up thinking it was more of petechial hemorrhages causing those events. There was a brain biopsy done that showed from the striatum that revealed a gliotic brain tissue with abundant gamistocytes, which is basically astrocytes on Shake Shack. It's basically just swollen astrocytes with protein layers in it, and in the basal ganglia, and that's affecting the movement disorder. So that's kind of the latest theory of what's happening. Overall, it's considered a benign condition with good prognostic outcome. CT scan, hypertenuation, and hyperdensities on the MRI, which you may see. Unfortunately, we didn't see it on this on our patient. So it was a Shake Shack. And I just liked it because it was shaking, and he did eat at the Shake Shack. Thanks to Dr. Tan. Cyril, I did steal some of his slides, my alpha kids, my nagging wife, and the hustlers.